All right, everybody, grab those notebooks, get settled, and let's get right into this explainer. We are diving into an incredibly intense, high-yield masterclass on oral and maxillofacial tumors today. I'm going to be your most demanding, yet most dedicated maxillofacial professor for this session. We're looking at the absolute critical foundations, the diagnostic traps, and the harsh clinical realities you're going to face on your board exams and, much more importantly, in your surgical chairs. This isn't just about passing tests, folks. It's literally about saving lives. So let's dive right in.
Here is our roadmap for today. We're going to cover the foundations of maxillofacial neoplasms, early detection signs, the sequential patient examination, advanced imaging and diagnostics, biopsy guidelines, and we'll finish up with high-yield clinical differentials. Let's keep the pace up.
Section 1. Foundations of maxillofacial neoplasms. We're building the pathology base right here.
Okay, this concept looks basic, right? But you wouldn't believe how many students fall for this classic board trap. Write this down in huge, bold letters. Tumor does not automatically mean cancer. No way. The word tumor originally just meant a swelling, and today it's synonymous with neoplasm, which is an abnormal growth of cells. It can be benign, it can be premalignant, or sure, it can be a malignant cancer. If I catch you using the word cancer interchangeably with tumor on my ward rounds, you're going to get a very stern look. Precision in your language is the very first step to precision in surgery.
Consider this a visual spotter exam. You need to instinctively know the biological difference between these two adaptive cell changes. Let's talk about hyperplasia first. That is an absolute increase in the number of cells. They resemble normal cells, but they're just proliferating way beyond normal limits. Now compare that to hypertrophy. That's an increase in the size of the individual cells, not the number. You've got to understand these cellular mechanics deep down, because it forms the foundation for absolutely everything that follows.
Section 2, Early Detection Clinical Signs, catching it before it's too late.
Let's rapid fire the why. Why are we so obsessive about catching these signs early? Well, it means easier treatment. It means the reconstruction after we remove the tumor isn't some massive, brutal graft. It means predictable outcomes and, frankly, a far better prognosis for the human being sitting right there in your chair. We catch it early, so there's no metastasis, no aggressive lymph node involvement, and a much lower treatment cost for the patient. This is exactly the why behind the rigorous protocols we're going to cover.
And missing those early signs has a harsh clinical reality. Think about encountering a massive, aggressive surface ulceration on the tongue. Here is the absolute rule you must memorize. Any surface ulceration that does not respond to treatment for 2 weeks requires your immediate, heightened suspicion. If you see rolled edges or a necrotic floor and a patient comes to you saying, "Doc, this sore just won't go away," you do not, I repeat, do not just prescribe another week of mouthwash. You investigate immediately.
Moving on to Section 3, the sequential patient examination. This is your non-negotiable diagnostic workflow.
I know those medical textbooks are incredibly dense, but you've got to chunk that theory down into this exact 6-step logical framework. You must use this for every single patient every single time. 1. Personal history. Age, sex, and occupation can hint at endemic diseases. 2. Chief complaint. 3. Medical history. Prior cancers mean potential metastasis. 4. Habits, like heavy tobacco use. 5. Clinical examination. And only then, step 6, diagnostic aids, like imaging. Never ever jump straight to an X-ray before you've carefully completed steps 1 through 5.
Let's take a quick breath and really internalize this. Always believe the patient and never underestimate him or his words, because he is the one who feels. Folks, this is the golden rule of clinical practice. Despite all of our advanced science, all the CT scans, all the biopsies, listening is your single most powerful diagnostic tool. Most tumors are entirely painless, right? But if they get infected, traumatized, or start encroaching on a sensory nerve, the patient's going to feel it. Listen to their chief complaint.
And when you're listening, you are listening for very specific red flags. Things like unexplained trismus, meaning they suddenly can't open their mouth, or floating teeth, which indicates rapid bone destruction around the roots. And listen up, here is a massive board alert. Paresthesia of the lower lip. If a patient reports a numb or tingling lower lip without any prior trauma or surgery, you must immediately suspect inferior alveolar nerve affection by an invading tumor. That is a hallmark sign of a serious problem.
All right, Section 4, Advanced Imaging and Diagnostics, Proving Your Suspicion. Let's talk plain radiographs. You absolutely have to know their limitations before you decide to order a CT or an MRI. Yes, plain films have great advantages,
They show if a lesion is radioopaque or radiolucent, they show root resorption, and they can tell you if the margins are well or ill-defined. But you have to remember the disadvantages. It's only a two-dimensional image of a three-dimensional object. You are going to get superimposition. And beware of panoramic views. They can have up to a 25% magnification error. You literally cannot use a 2D panoramic film to definitively measure an aggressive tumor's exact proximity to the carotid artery. You need a 3D scan for that.
Let's treat this next part like a mock board question on radionuclide bone scans. A substance labeled with the radioactive isotope technetium-99m is injected into the patient. Why do we do this? Because this isotope acts like a heat-seeking missile for areas of high metabolic activity in the bone. When you see a hotspot on one of these scans, it indicates incredibly active bone turnover, which points directly to metastasis or a highly active bone lesion. This is exactly how we hunt down metastatic spread.
Section 5. Biopsy Guidelines and Techniques. Tissue is the issue. But before you grab that scalpel, you need to know when absolutely not to cut. Huge, screaming board alert right here. There are absolute contraindications to performing a standard incisional biopsy in the clinic. Number 1, vascular lesions, like a hemangioma. You cut into that without prep, and you will have a catastrophic bleeding event on your hands. Number 2, malignant melanoma. Doing an incisional biopsy, meaning just taking a piece, on a melanoma is a fatal error. It can trigger rapid, uncontrollable metastasis. You must know these contraindications cold.
Now, when you are safe to proceed with an incisional biopsy, technique is absolutely everything. An undesirable biopsy is broad and shallow. It's basically a useless scrape of necrotic tissue that gives the pathologist absolutely nothing to work with. The desirable technique is a deep, narrow incision that extends down past the lesion into the normal underlying tissue. You must capture the deep architecture of the lesion and include a safety margin of normal tissue. That way, the pathologist can see the exact transition zone between the healthy cells and the malignant cells.
All right, final sprint. Section 6, High-Yield Clinical Differentials. The final exam rapid fire. You need to mentally file away these anatomical locations right now because they drastically narrow down your differential diagnosis. If you see a swelling on the palate, your brain should immediately snap to adenocystic carcinoma, torus palatinus, palatal abscess, or pleomorphic adenoma. Swelling in the floor of the mouth, start thinking ranula, dermoid cyst, Ludwig's angina, or a lymphoepithelial cyst. On the cheek, papilloma or verrucous carcinoma. If you lock these specific localizations into your memory, you're going to save critical time formulating your diagnostic plan.
So let's wrap this up with a challenge for you. We've just powered through the biological foundations, the red flags, the sequential exam, imaging limits, strict biopsy rules, and anatomical differentials. My final question to you is this. How are you going to apply this sequential knowledge the very next time a patient sits in your chair with an unexplained radiolucency on a film? Are you just going to guess? Or are you going to use this masterclass framework to be a brilliant diagnostician? The difference between a good practitioner and a truly great one is in the structure of their thinking. Never stop questioning and never stop learning.